Good morning. Today we are having an interesting and a little tricky case. Here is a 70-year-old female presented with non-ST elevation myocardial infarction. And angiogram we are going to show you in short. She is also a known case of chronic bronchitis with the diabetes and the hypertension as the comorbid conditions. And her renal functions were normal. Syntax score 27. So this is the angiogram. So we can see in LAO cranial there is a critical ostial left main aorta ostial lesion stenosis, and in RAO caudal, apart from that left main lesion, there is no significant lesions were noted. So with the syntax score of 27 less than 33, and this is the aorta you can see in this particular view. This is a clear porcelain aorta. So surgeons were a little bit hesitant to operate on this case, and we can see even bronchus is hugely calcified, and RC is a non-dominant, very small, diffusely diseased vessel. So there is a critical aorto-ostial left main stenosis with syntax score of less than 33 with the calcified porcelain aorta. So we decided to go ahead with the PCI with some calcium modification. And the device we are going to use for this particular calcified lesion is the intravascular lithotripsy. Over to Dr. Ajit.
Good morning. And what we're going to show you first is this is a very critical left main. Can we run the angiograms of today? So we have a bilateral access, right femoral artery 7 French, left femoral artery 6 French. Why 6 French on the left? In case there's a requirement for intra-aortic balloon pump, we can put that in. You can see that I am wiring from outside. Can I have the next shot? Yeah, so I'm wiring from outside the left main. I'm not cannulating the left main because the pressure damps immediately. So I have two wires. There's a very crooked vessel, and you can see that the LAD wire is the BMW, which is going down. And we can see that there's another wire just for support in the diagonal in case I have difficulty in tracking either the balloon or the IVUS or the lithotripsy catheter. So you can see the critical left main, and there's a lot of calcium even on the fluoro. But we will now do the next steps. So what we've done next is used a 2mm balloon to predilate the whole thing for the IVUS transmission. So we can see that the balloon has some waste, but it comes up at high pressure. And now we will show you live the intravascular ultrasound, after which we'll decide what we are next going to do. I hope the IVUS tracks down this catheter, and we go to the PA cranial for tracking the IVUS down. So I'm just going to get the IVUS down, and we can see I've put it down the diagonal. Maybe what we can do is put it down the other catheter so that we have a better picture of the LAD. Yeah. So what our plan is to get the IVUS down, have a look at the IVUS of the LAD and the left main, and then have a look as what is to be done next. Can we put the
So the option of imaging between OCT and IVUS, obviously in the aorto-ostial lesion, when the guide could not be engaged, it's only the IVUS. And though there are some techniques described for the OCT for the aorto-ostial lesion, I think those techniques are going to be not easy in this particular anatomy. Hence, IVUS is a preferred treatment. Even suppose if there is no aorto-ostial lesions also, I personally prefer IVUS is a better imaging modality than OCT, because the choice of the IVUS, lithotripsy balloon sizing is going to be made by the vessel size. The EEM we are going to see only in the IVUS, definitely not in the OCT. So at the site of block, suppose if it is remodeled, vessel size is small, or it is positively remodeled, vessel size is big. So IVUS is going to give a clear picture rather than OCT.
So I think you can see how difficult the IVUS catheter finds. Even there's a calcification there in the LAD. That's at the bifurcation of the second diagonal. Anyway, let's go ahead and look from here.
So this is the clean area in the LAD we are starting. I am starting the pullback. As the catheter moves back We can see the clear 3-layer structure. There is a branch joining, which is the diagonal, and we can see there is another diagonal joins with the wire, and here it is maybe the circ joints, and this is the left main. I think not much block even in the left main except one eccentric block. In the shaft it is clean. As we are going towards the ostium, we can see clearly it is a critical tight stenosis with the calcified lesion. So here we stop. Let's analyze after pulling out the IVUS catheter. So in the LAD, proximal LAD, the diagonal joints, no blocks, some eccentric blocks in the left main. And as we are coming close, we can see clearly the vessel size is also not big. So here maybe in the shaft, if I measure the vessel size, it's 5.5 millimeter cross 5. So approximately 5.25 average size. Whereas as I'm coming towards the ostium,
Solve this.
I can see one EM at 12 o'clock here, and here another EM. So it is only 3.9 in vertical axis, and here actually I should not measure because it is ioto-ostium. Maybe I'm continuing the EM as a imaginary line and I'm measuring. So it's going to be around 4 at the ioto-ostium. Though it is 4, we are not going to choose 4 size because the luminal diameter is 2.5. So just the balloon has to get contact with the lumen. So between 2.5 and 4, somewhere I think 3.5 maybe the size of the IVL balloon. I feel. What do you think, Dr. Raji?
Yeah, well, two issues. One is the calcification is significant, but it's not 360. You can see that. But you can see that there is reasonable calcification. So the question is whether we need IVL or we don't need IVL, but it's eccentric hard calcium. And you can see that with a cutting balloon, we are not going to open that calcium up significantly. And number two, the rotablator will just pass through without even touching that calcium. So even if you have a wire bias on the rotablator, we're not going to have that. So the first issue, do I need IVL or not? The answer may be yes. We could possibly get away with no IVL, but I plan to use the IVL here. The next issue is what diameter. As Dr. Nandakumar said, it's the contact it is at about 2.7, 2.8. Is that Nanda?
2.5 is the lumen size, where the vessel size is 4.
So I think a 3.5 would be a reasonable amount, because I think the left main, once it opens up, is going to be pretty large, and it's going to be at least close to a 4. So I think I'm going to open up a 3.5 IVL balloon. So can we get that IVL balloon ready, please, now? Yeah. So as he gets the balloon ready, can we just play the other components of the IVL? So maybe you have 3 parts of the IVL, the catheter, which has to be prepped like any balloon with the components having the ultrasound at the tip. We have the catheter attached to a connector, which is a cable which connects to the power source. And then what we really do is that we deliver. These catheters can deliver about 80 pulses. That is about 8 pulses of 10 each. I hope that we can, use all the 10 pulses each time and use it. As Dr. Nandakumar showed on the IVUS, there's not much disease at the distal left main or the proximal LAD. So we need to concentrate on the, basically on the left main and deliver the maximum shocks there. Okay, and now can we go to the next slide, please? And so the IVL delivers shocks, which makes the calcific plaque pliable. That's the principle. And each pulse will deliver, we have 8 pulses, 8 cycles possible, with each pulse about 10. We can shorten it to about 5 pulses if required, if the patient doesn't tolerate it. Because you can see this is a left dominant circulation, and we may have that trouble, and we may have to shut the pulse off at about 5. Now, it delivers pressure at about 50 atmospheres at low inflation. So it's very important that you don't go more than 4 and 6 with this balloon. because it can cause a rupture if we go very high. What we need to also understand that unlike the debulking methods that we see with the on the eye imaging with OCT and IVUS of other techniques like rotoblator and cutting balloon, we may not get the classical cuts. We could get, but we may not get the classical cuts that we would normally see on an imaging. It sort of softens the plaque in a way. And post IVL, we always need to use low pressure. Now, when we prepare the balloon, it's very important that all the air is prepped out of the balloon, because if there is air in the IVL balloon, the shocks will not be delivered appropriately. My plan here is to deliver the catheter just approximately 50% into the left main, and 50% will be outside. Okay? And so we've got, I agree that, we would go ahead with a 3.5.
Lights.
And we now put the catheter into the pressure source, power source. So the power source is ready. Okay. And we keep the balloon here. And you can move the IVUS out of the way, please, sister. Okay. Now, what we'll have to do when I say to press the power is, Ram, you need to just press on that when I tell you, okay?
So I can hold till the time you say.
So there are 3 emitters in the balloon. Here, it's only 2 emitters in the coronary balloons. So peripheral, I think it's 3 emitters. So in the 2 emitter, at least 1 emitter should be at the lesion site. We have to make sure.
Okay, it's got a little bit of a long monorail. Please hold the wire here, please. And what we're going to do now is quickly get the 3.5 coronary IVL shockwave lithotripsy balloon down into the left main. And then once we are at the site, we will inflate. There is no trouble in keeping 2 wires when we're doing an IVL. That's a good part of the whole story. I hope this IVL catheter will track down the left main. We had not much difficulty in the left main with the, so here is the catheter coming, and I think we are through. So we are cross, the pressure is okay, small check please. Okay, we got to go a bit further. Small check please.
Yeah.
You can see it's a little difficult to track down. I think we've crossed the left main. Take a shot.
Yeah.
Okay, so I think we are across the left main. I'll reduce the pressure on the catheter. We're releasing the guide. And now I will go up with the balloon at 4 atmospheres. And then Ram, when I tell you,
Yeah.
we can start the pulses. So let me just first go up with the balloon. You can see the balloon coming up. That's at 4. And now press on the,
Yeah.
please press.
Yeah. Yeah. Continuous press. Which thing?
Sir, can you deflate for some time, sir?
Yeah, so
The
the push
pressures are
button
going
has
down.
to be pressed on the side. So we've just got the pressure down a bit as the patient had a little bit of hypertension.
We'll pull back the balloon for some
Yeah,
time.
it's having a good drink.
Okay,
no
now its
problem.
pressures are
There
improving.
was a little bit of a disconnect there. So we're going to do that. So
Yes.
this, yeah, so we need to now go up again. And
Yeah.
we are up to 4 now. Press,
Sir, I
please,
go?
continuously.
Yeah.
You can hear the noise now of the pulse, and you can see the pressure pulse there. Continue the pressure. And we saw the pressure fall. So we have deflated it. Now I'm going to inflate it again at 4. So we had 5 pulses, and now we go up again.
Deflate, sir.
Okay, so this was done. The first round is over. So let's see how it happens. The next round we'll do the full 10, please, because let's hope that he can tolerate the pressure as well. Okay, let's take a small shot here. Okay,
Shall we take a IVUS and then?
yeah, I think we should do all the few shots and then go ahead. So let's go ahead with one more round of the whole thing. So now we will do all the 10, okay? So we're getting to the next round. And now we are at 4. And now you press 3, 4, 5, 6, 7, 8,
9,
10.
10. Yeah.
Pressure
Let the
dropping,
wait of
sir.
a bit
Deflate,
of a
sir.
second and we deflate. Okay. So now I'm going to change the direction of the catheter. A little bit
Sir,
of
we'll allow
pressure
some
drop.
coronary perfusion. Pressures are dropping.
Okay, I'm just pulling the catheter out and letting it have a drink. So it's very important in these left mains to do this very slowly and do it comfortably rather than in a hurry. So we have now given 2 shots. I think this may be good enough, but let me see what we can do once more. And then we'll have a full cycle of 10 and then have an IVUS look, okay? As you know, these balloons are very, very, very bulky balloons, and going in and out is a bit of a issue, but let me hope I can get this down again. Okay, we got it back in.
Yeah, went in.
Okay, small check. Okay, a little
That's
bit
okay.
further. Okay, that's good. Okay, now we're going to go up again. Okay, so I'm going to go up full again to, so we'll give the entire 10 cycle this time again. So we are at 4 now. Okay, go ahead.
Starting.
On.
1, 2, 3.
And these shockwave
4,
pulses are not capturing
5,
the heart. We can see
6,
clearly there is a
7,
dissociation between the shockwave
8,
pulses and the arterial
9,
pressure tracings.
10.
Deflate, sir.
Okay, so we've done something with the IVL now. I'm letting the balloon deflate. The pressure came down, and I will just bring the balloon back. Let the pressure come up, and we'll do an IVUS now. Okay. So this was a 3.5 IVL. Okay, get the IVUS, please. Keep it there, please. We'll need some more IVUS. So the pressures are good. Get the IVUS, please.
IVUS കൊടുക്കുക.
Okay, so what we're now going to do quickly with an IVUS is to see what we've done. And Nanda will read the IVUS. As you saw, we gave 3 pulses of 10 cycles of IVL shocks.
Light.
Come forward with the IVUS, please.
Yeah.
You can see now the IVUS passes through the left main pretty easily.
Yes, it is just after the diagonal in a good area. I'm starting pull back.
And we can see the IVUS now, please.
So this is septal. Now it's joining at 10 o'clock position, and a diagonal is coming at 3 o'clock position with the wire. what we need to see is any dissection flap is extending because of the IVL down to the LAD, which is not here post IVL. There is no dissection flap in the LAD. And we can see the diagonal joints at again LCX joints at 3 o'clock. And this is a left main. There is a minimal amount of calcium, no dissection flap in the shaft of the left main. The same eccentric block remains as such as we are closing towards the ostial left main. Still there is no flap, and here comes the lesion. It's reasonably the same, and
Tight ostial.
no obvious cuts also noted. As we expect, we may not see any cuts here. It's basically spongify. The calcium cuts are better seen with the OCT catheter.
So Nanda, can you just show the pictures again for ourselves and for the viewers?
So this is the aorta ostial 180-degree calcium, the arc, and this the left side of the screen is the aorta, and right side is the left main wall. As we move in, the calcium is only limited from 4 o'clock to 7 o'clock position. And here maybe we can say some micro dissections, some tracks are seen here, some 2 tracks. Apart from that,
IVL.
we don't expect anything also. It's just to spongify the calcium and to expand the stent in a better way. And fluoroscopically, we have seen clear expansion of the IVL balloon.
Okay, can you show the fluoroscopy again to show the expansion of the fluoroscopy balloon? Yeah, so you can see that it's pretty much open at 3.5. So I think basically we have prepared the artery well enough. And now we need to
Now deciding the stent, I think there is no further predilatation is required. So the left main bifurcation is here just above the carina. Here if you see the size, the minor axis it is 2.8, in the major axis it is 4.2. So 4.25, somewhere 3.75 to 4 is the distal size. And ostium, as we already discussed, it's little negatively remodeled area. So maybe this portion of the ostial left main we can take for sizing. It's again for, I think 4 is the diameter of the stent we are going to take, and we need to come up to this ostial portion. So now there is another question: are we going to stop at the lower margin of the left main or at the upper margin of the left main? There is new guidelines from the EBC saying to stop at the lower margin, because during the post dilatation the stent may elongate to cover the upper margin. The length is 11.9. So anything 412 stent is going to just stop at the carina of the left main, 1 millimeter protruding into the ostium of the left main.
Yeah, so what we could do is basically take a 12 and maybe keep 1 millimeter out, or maybe take
even 2-3 millimeters out, it is going to land inside the left.
So I think basically what I will do is take a 412 and deploy that at nominal pressure, because with an IVL, usually the vessel is spongified and open. So we need a 412. Can we get an onyx or a synergy stent, please? So what we need to do is basically get a stent which is 4.0, and then we will see how it comes up and then decide. And as the EBC criteria says lower border, so we'll go to the the LAO cranial and see the lower border, and then position our stent carefully there. Any other comments?
So at the shaft of the left main, the vessel size is 5 to 5.25. So maybe we will take a post dilatation balloon 5 and do it, and if at all malopposition is there, then we will take a call too.
Okay, so the idea is not, because it's negatively remodeled at the left main ostium, I don't want to go up much higher there. Maybe you can use a short 4.5 or 5.8 just to do the distal and do. Open up the 4.0, please. Onyx 4, yeah, 12. Now I use this second wire, and you can see there are 2 wires here. One is a extra support wire just to help the tracking, and the other is a floppy wire for tracking all the catheters in. So basically, we used two wires in this area, and even you saw that even with the two wires, the IVL had difficulty in moving through that lesion. So we need to have extra support wires always for IVL. I always use that. I would suggest every operator to use a strong wire, especially when we don't have guide support like this patient, where your guide is loose in the left, in the aorta. So this is a 412 onyx, and we're going up, and as what Dr. Nandakumar told us, we're going to land it just before the bifurcation and a little. So let's go LAO cranial, please, first.
Would you like to wire the circ, or it's okay? Circ
I
costume is free
think
of
the
basis.
costume is free. I'm not going to go very distal into the bifurcation. And it's a very tortuous vessel. You can see that LED wire. There was a lot of concertina when you went in. That's okay. So can we get a small shot now?
Yeah.
So we'll now do a cine here.
Yeah.
So we
Yeah.
need to get further around that. So going to get the guiding in. And that's the
Yeah.
stent through. Pull that wire back
Yeah.
now that I've got the support. Small check.
Yeah.
Okay. Bring it a millimeter back and go to the RAO caudal. Now I think we're just at the ostium. The pressures are good.
RAO
Come to the RAO caudal, please. Just to be sure we have not crossed the bifurcation. Take a cine.
Yeah.
So we have crossed
Yeah.
that bifurcation,
Yeah.
so we need to come back.
Come back.
Small check.
Yeah.
Still
Still
across
at
the bifurcation. Go to the LAO caudal. Pressure on. So be very careful here that we are not across the bifurcation. So we are just
Yeah.
at the bifurcation. Maybe pull back a
Yeah.
millimeter.
Maybe 1 millimeter.
Bit. We'll have a few millimeter outside here.
Yeah.
No, sir, it's okay. I think we'll pull back.
I think we should be back a millimeter. Okay, small check, please.
Yeah.
Small check. Okay, that seems to be all right, isn't it, Nanda?
Yes.
Let's take one cine here.
Yeah.
We'll check in elevocranial once again.
We'll go to the eleocranial.
Now we are away from that bifurcation, 1 millimeter.
Yeah. Okay. I think we are done with the osteo.
We need to come back.
Maybe
big
little
back,
bit
okay.
come back.
So you can see
Still
how
that calcium
important
is
it is to take the pictures rightly.
Yeah.
So now we're okay. Let's take one cine here.
Yeah.
As you know, the stent arises outside
Yeah.
the marker. That's good, I
Little
think.
exactly there.
This
What do you
looks
think?
okay.
That's perfect?
Yeah.
Okay, let's go up there now. Go up
Chalo.
slowly. 2, 4,
2, 4,
5,
5,
6,
6,
7,
7,
Oh,
8,
it's
9,
9,
10,
10,
11.
11,
Nominal at 12. Yeah.
12.
Deflate.
Deflate.
so. I think the stent moved a little back during the inflation into the left main ostium.
The stent did move a bit, but I think that's expected because I was pushing the balloon, but it still moved a bit back. But there's no disease at the bifurcation, so it's okay. So I'm just going to go up a bit again here. Go up here.
Yeah.
Yeah. 12
2,
again.
3, 4, 5, 6, 7, 8, 9, 10,
11, 12. Deflate.
deflate.
We will do a IVUS, then we will take a call for post dilatation.
Okay. So we'll now just flare it a bit. I'm pulling it back. Flare that, please. Flare it.
4, 6,
Okay,
8,
9, 10, 11, 12,
12,
13, 14,
13, 14,
14, 15.
15.
Deflate. And now we'll get the guiding slowly over the balloon into the stent and then release the stent out. Okay,
Ready for the IVUS system.
we'll take a shot now down and then Nanda will take an IVUS picture. Okay, so let's take one shot here.
Yeah.
It's a bit underdone. We need to do some work there.
Yeah.
Okay. Okay, so let me get me a balloon. What do you think? Photo shot?
Yeah.
It's a bit underdone. Yeah.
Ostium is pinching.
Yeah, I think there's some calcium there and we need to do that.
Yeah, we will first do with the 4O NC
Yeah.
balloon, then we will take IVUS.
Give me a photo NC, please. Keep this wire out.
Maybe short
4 NC,
8,
short
6,
6.
something like that.
6 or 8, yeah.
Actually, it didn't move much back. It looks
It's all
exactly at
right,
the
but I
ostium
think we
only.
only have to be careful when we get the balloon across that we don't hit the top of the stent. Can you move to the LAO caudal? Show me the deployment of the stent, Cine, please. It looks reasonably up, it doesn't look as if it's underdone, but obviously the left main is one area, ostium, which is a very strong area. You can get elastic recoil, so we'll need to push it up as much as possible. Show me the,
Sometimes it may be eccentrically opened. In this particular angle, it shows,
yes, please.
in a IVUS, it may be showing a oval, well expanded stent.
So this is a 406, please.
Yeah, 4.
Okay, so I'm just going to be very carefully going down that. You can see the difficulty now. Okay, so let me do one thing. We will go down to the other view, LAO-cranial, please.
Guiding is going inside the stent easily.
Sadharana muchuttingama.
Normal amuchuma.
So you can see the difficulty because of the eccentric landing of the stent. I'm just inching my way through very, very slowly. Okay,
Yeah, I think
it's
it
very
is.
important not to disturb the ostium or disturb the. So we are now distal
Yeah.
area. We're just slowly getting that down. Okay, I'm going to do a cine to see whether we are inside the stent.
Yeah, we are
Difficult to
inside.
make out, but come to the ariocaudal. And I need the stent boost here, please. Please get a stent boost down.
Yeah, we are outside the
We are
stent.
outside the stent, so we need to come back. And you can see that it is. Okay, now go up. 8, 10, 12, 14,
Yeah,
16,
going up.
18, 20.
8, 10, 12, 14,
In 16,
16,
18, 20.
18,
Hold
20.
it there.
Yeah, 20 holding.
Deflate.
Deflate.
Go up 20.
8, 10, 12, 14,
14, 16, 18, 20.
18,
Go straight
20.
into the iliocranial, please. Keep the pressure there. Yeah, keep the pressure there. So you can see that it is well deployed, deflate.
Different.
So I've taken two views just to be sure and rotated the gantries to be sure that we got a good opening. Then I come back and pull the guiding out. Go up there, please, again, 20. 20.
Yeah.
Go up, 20,
18, 16, 20,
18, 20.
20.
And let's hold it there.
Yeah.
Deflating.
Different.
And now we're going to flare it at the ostium. Go up there.
Going
Flare.
up. Yeah.
20,
20,
22,
22,
24.
24.
Yeah, deflate. Flare 22, 24.
Going up. 20, 22, 24.
Deflate.
Different.
Flare 22, 24.
Going up. 20, 22, 24.
Deflate. So she's tolerated that reasonably. So hopefully this has done the trick. And we try to get an IVUS now and see what we've done. So we went up to 24 with a photo. Let's take one cine, please. Aspirate, please. Yeah. So I think we have got a reasonable, it's a guiding is inside, but we'll take the IVUS and see it. But the guiding is not really compromising anything. So we'll get down the IVUS and then pull the guiding out and check the whole stent. The issue is whether we need, so 4.0 at 24 is how much, sister, please? What is the size at 4.0 24, please? 4.3? Okay, so we have reached 4.3 now. Go back to the cranial, please. Can you remove the slightly off? Okay, so the catheter moves in nicely. There's no problem.
Yeah, we have
there.
passed the area, good area. I'm starting pull back.
Yes, please.
So again, after the stenting, we need to see any dissection is there into the LAD. There is no dissection into the proximal portion of the LAD. We can see the septal joints at 9 o'clock, and we are expecting diagonal anytime joints at 3 o'clock position. Yes, the diagonal is coming and joining. Even before the first diagonal, the LAD looks clean. As we are going towards the ostial LAD, circ is joining, and circ is also free of dissection here. And soon we can expect a stent. Yeah, the stent is starting, and it is well opposed. Now here there is some mole opposition. We know there this is the area of 5 or 5.5 millimeter, the minimal mole opposition. Again, as we are coming towards ostium, it is well expanded. We can see the oval expansion. That is why in that particular view it is seen as a, and there are a little bit stent protrusion into the left main. We will measure how much it is protruded. I'm stopping here.
So,
So the first thing, distal edge, it is clean, no edge dissection, well expanded. Then I'm going to see the malopose area measurements. It's 530 microns. Maybe we can go with the 5 millimeter short balloon only in the middle portion, not at the distal edge, not at the proximal edge, just in the shaft of the left main. And the malopposition length is, so here it starts and here it ends.
What's the lumen at that area where it's malopose, please?
So the length of the molar position is 3.2 millimeter. Definitely we need to address it more than 3 millimeter. What are you asking?
No, I'm asking you the lumen area
Okay,
at the
the
side.
MSA at the ostial left main, I hope it is going to be 11, 12, or even more than this. So it's 14.
Okay.
And the length of the stent which is extending into the left main, 4 millimeter into the left main.
Outside the left main. Yeah.
Outside the
So
left main.
there's a few millimeters outside the left main.
So it's a micro chimney. Nothing to worry, I think.
Nothing to worry about that. Now my issue is whether we should use a
The expansion is good. Only thing is there is a molar position of 3 millimeter length in the shaft of the left main, which needs to be addressed with a short 5-6 balloon.
Okay.
That balloon has to be placed not at the distal edge, not at the proximal edge, exactly in the middle portion.
Okay, let me see how it goes. I'll take that suggestion, but overall, except for that, we had a few millimeters. We wanted 2 millimeters. We've got 4 millimeters for chimney into the aorta. But in an ostial, we always have this issue. Either we had only 1 millimeter into the bifurcation. We didn't want to get into the bifurcation and dissect it.
So we are having a pot PTCA balloon at 5-6.
No, I would rather have a routine 5. I want a little taper on the 5. Yeah, the pot has no taper, and the problem is, when you go through this stent in the ostium, you got to be very careful that you don't distort the stent. The pot balloon has no shoulders. Very good for Let me just have a routine 5. What are we giving us? NC quantum. Okay, that's fine. Yeah. You need to be very careful as you go in that we don't distort any part of the stent, and that's the key here.
Even if we are coming out into the left main, no problem, but we should not go at the distal edge. At least we have to 3 millimeter away from the distal edge.
Can I know how much away are we from the bifurcation, the stent? Is it a millimeter or more?
So this is the figure of 8 polygon of confluence. And this is the distal edge. .79 millimeter is the.
So maybe distance. We could have pushed a bit.
The same that the 3.7 actually came into the left main.
Yeah. So if we had pushed in a bit the stent, maybe it would have been okay. But as you saw, as we deployed the stent moved back. And I think the reason is because as the stent straightens and at an acute curve, the stent will move back. And though I was putting pressure, it would do that. But anyway, let's go to the LAO caudal, please, again. LAO caudal, please. So I'm floating the guiding. You should not have it anywhere near the stent.
Another interesting thing is the length of the stent in the IVUS is exactly 12. So it neither elongate nor shortens after deployment and post dilatation.
Okay, so we're now through. Then now you re-engage the balloon. So what we are now in the stent, go back to the PA cranial. So now we need to go a bit distal. I'm just going gentle pressure with the balloon. And I just want to go to the RAO caudal now. We take a shot. So we are away from the bifurcation. Yes, we are away from the bifurcation. We are within the stent and we go up. Yeah.
So going up with your 5 millimeter balloon.
Just go
6,
to nominal,
7,
please.
8,
9, 10.
10, 12.
So that's a 5 deflate. Go up here, please.
5, 12.
Deflate,
Get
inflate. PA cranial now on the
12.
move quickly. So you can see it's well applied. Deflate, please.
Yeah.
And we flare it now. Go up, please. IVUS ready.
Yeah. 12.
Deflate.
Get.
So I'm just getting the guiding in as it is deflating. So she tolerated the procedure well. And we'll now get the IVUS again and see what we've done. So Danda has advised us quite nicely what to do based on the IVUS, and I will now have a look at the picture on the angio after the IVUS. So there's no pressure fall, there's nothing, so we don't need a shot now. Let's get the IVUS in. Thank you. So we now got the IVUS catheter back in. It's important to reduce the angle of the IVUS over the stent so that the stent doesn't hit the top of the IVUS monorail. So you saw me
It's
just
in the good
releasing
area,
the
sir.
guide. Okay, now we are distal and we're going to take some pictures now again. Thanks.
So again, the same areas we are going to see at, yeah, the first now the septal joints. After that, we can see the diagonal. Okay, I think the first one we have started with the diagonal. So now we are in the left main. This is the distal edge looking clean. And shaft, this is the area of molar position. Now it is well opposed. No molar position after the 5 millimeter post dilatation. And as we are coming closer to the ostium, we can see even better expanded stent compared to the previous one. And as we see that 3.5 to 4 millimeter of stent extending into the aorta ostium. So we stop
Okay.
here and I am measuring the at the distal edge of the stent, the reference area.
Can we get
So
some dimensions now?
it's 14 millimeter square is the distal reference. And this is the area of molar position. There is no molar position. We can clearly see everywhere it is well opposed stent. And this is the aorta ostium, that oval expansion area. And these are all artifacts. Stents looks as if it is vertically positioned. Actually, these are artifacts, which is commonly seen at the LM ostium. So it is 14.36 compared to 13.98. It is more than 100% expansion. The ostium is a very well expanded stent, no molar position, no distal edge dissection. And we can see here the LCX and LAD is clean of any dissection and block. So I think we are done.
Okay, so we showed you a case where there is a, so we'll take a picture and then Ram, and then maybe discuss the case in a minute. So let's take a shot. Okay, that's perfect, you know. So you can see nicely one more view. The important thing is not to disengage the wire now because you lose the left main. I'm keeping the guiding all the time out, not to hit the ostium, so that we don't have any problems with the stent protruding into the aorta-ostial junction. So Clearly, we're not worried. That circumflex which you see on the angiogram is not an issue. It is basically clean on the IVUS, so you can safely leave the whole thing alone. And I'll just get the wire into the guiding to just see that bifurcation one shot. Go to the eleocranial. We're done. Okay, so all you can see all the branches there. The LAD is flowing freely. Show me the previous two pictures.
This looks perfect.
And here in the IVUS, we can see in the long view,
Yes.
first one is the circ is going up and second one is the diagonal going up. Both the ostiums are clearly open.
So I think we are done here. I think Nanda and Ram, we are okay with all this?
Yes.
Okay. Okay, so the learning in this case is basically, we can remove the guiding, Nanda, Ram. So the learning in this case is an IVUS-Ostial left main stenosis with 180 degrees calcium, which we crossed with a 2 mm balloon. It was a 90% stenosis, difficulty in tracking the IVUS first, even with a 2 mm dilatation, took the pictures of the IVUS, showed the lesion restricted to the tight left main ostium, which was clearly significant. The left main bifurcation was not involved. The LADs were having disease, but the lumens are good. We then used a 3.5 IVL balloon to debulk the lesion. We took three shocks of 10, and then we saw that the balloon had expanded well after that. Obviously, we didn't see obvious cuts, which is seen not often with an IVL. The IVL just softs the lesion, but you could see the balloon nicely expand after the IVL was delivered. Following which, we put a 4.0 into 12 mm stent, trying to avoid the bifurcation and have minimum protrusion to left main. We got a couple of millimeters extra protrusion to the left main, which is like a chimney into the left main. That's not an issue as long as you don't disturb it with the guiding catheter. We did the IVUS post dilatation with a 4 mm balloon, saw some malapposition in the mid segment of the stent, which we did with a 5 mm balloon, did the ostium and the proximal left main stent with a 5 mm balloon, and got 100% expansion with no malapposition and no dissection. The case shows how we can do a critical left main in a patient with a posterior aorta who's a non-surgical candidate with interventional coronary imaging and debulking and stenting. Thank you very much, and we will move on to the next case in the next lab. Thank my colleagues, Dr. Nandakumar, Ram Kumar, colleagues from my nurses and techs for showing the case, and I hope you all enjoyed it. Thank you very much.